As summer winds down and I start rotating my closet, I've been on the hunt for some staple pieces that are comfy, polished, and versatile. Things I can actually layer and wear on repeat. Quince totally nails it. Their collection feels so elevated. Think soft cashmere and cotton sweaters starting at just $40. Washable silk tops, classic denim. These are timeless styles that make it easy to look put together without trying too hard, which, let's be honest, is the goal when life is busy. I've been eyeing the Nina Stretch Pull-On Flare Jeans and the 100% organic cotton boxy V-Necks tee. I'm all about those easy layers. And the price? That tee is just $15. You cannot beat that. The best part is that Quince works directly with top artisans and cuts out the middlemen, so you get high-end quality at half the price of similar brands. Elevate your fall wardrobe essentials with Quince. Go to quince.com/nursemo for free shipping on your order and 365-day returns. That's QUINCE.com/nursemo to get free shipping and 365-day returns. Quince.com/nursemo. Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in nursing school and at the bedside. Today, we are diving into an anesthesia topic, so hang on for that. Before we do that, though, let's take a quick minute for a listener shout out to Jessica, who says, I'm a non-traditional student in my first semester of nursing school. I have an hour-long commute, so I was looking for a podcast to fill the time and help me think like a nurse. Nursing school is a lot like learning a new language, and I find it helpful to listen to Nurse Mo speak the language during my commute to and from school. The podcast and study sesh pod quizzes are a great way to start my day at 6 a.m. and get my mind ready for class. I've learned so much already in just 3 short weeks. Jessica, thank you so much for sharing your experience and how you're using the podcast to help you thrive in nursing school. I'm so proud of you. Keep going. You've got this. Alrighty, so today we're talking about anesthesia with a little bit of an intro into anesthetic gases. So if you're heading into maybe a perioperative clinical rotation, even a perioperative exam, or are transitioning in your practice to surgical nursing or PACU nursing, this podcast episode will provide just a kind of a basic overview of anesthetic gases. So first, what are anesthetic gases? So these gases, which are also referred to sometimes as inhaled anesthetics, are substances used to basically produce anesthesia for surgery. They quickly enter arterial blood via pulmonary circulation. They're inhaled, they go into the lungs, they go into pulmonary circulation, they quickly then enter arterial blood, allowing for efficient anesthetic induction, and when you take it away, discontinuation. So looking at how they work, I'm not going to go into the chemistry. We don't need to do all of that. We're not in CRNA school, right? But just in a general sense, anesthetic gases depress neurotransmission of excitatory paths involving acetylcholine, glutamate, and serotonin within the central nervous system. Now, they also augment inhibitory signals, including chloride and potassium channels. So all these disruptions working together induce a state of unconsciousness and immobility and amnesia. And some inhaled anesthetics can also have an analgesic effect. So they do a lot of stuff. Basically, they are making the patient unconscious and unaware of what's going on so that we can do really intense things in surgery. So there are 2 types of anesthetic gases, volatile and non-volatile. So volatile anesthetics have low vapor pressure and a high boiling point. So low vapor pressure and a high boiling point. This means they are liquid at room temperature and must be vaporized for administration. The volatile anesthetic gases are halothane, isoflurane, desflurane, and sevoflurane. Notice they all end in ane, A-N-E. Again, those were halothane, isoflurane, desflurane, and sevoflurane. Again, they all end in ANE. So those were the volatile anesthetics. They have to be vaporized for administration. Non-volatile anesthetics have high vapor pressure and a low boiling point. This means they are in gas form at room temperature. Nitrous oxide is a non-volatile anesthetic gas, and it is used frequently in dentistry as well as along with other components in general anesthesia. It's not strong enough on its own to induce that full amnesia, full immobility, full unconsciousness. So it is often used in conjunction with other things when those results are necessary, but then it's also used in dentistry where you just need a little bit of that effect. I don't know if you've ever had nitrous oxide. I definitely got it as a kid when I would go to the dentist, and I was tripping. Like, it was weird, but it made the dentist a lot less scary. So there you go. Alrighty, so let's go through a few key points about each of the anesthetic gases when we get back from this quick break. As nurses and future nurses, we all know a shift starts before you even step foot on the unit. What you wear sets the tone for your entire day, and that is why FIGs are so great. FIGs make scrubs for modern medicine. Back in nursing school, I was handed these boxy, scratchy, stiff, uncomfortable scrubs that honestly felt like wearing a paper bag. But FIGs is changing that. The fit is flattering, they're insanely comfortable, and they actually are made for people who work in healthcare. They're also antimicrobial to help keep you protected, durable enough for wash after wash after wash, and look so good you actually want to wear them. If you're getting your first set of FIGs, I'd go for the Catarina top and the Cade pants. The Catarina has an easy, relaxed fit, and the Cade pants have cargo pockets for everything you need within easy reach. You can get 15% off your first order at wearfigs.com with the code FIGSRX at checkout. That's wearfigs.com, code FIGSRX for 15% off.
Introducing the perfect companion to your morning listening routine. AG1's clinically backed formula is now flavor-packed with 3 new delicious flavors: tropical, berry, and citrus. Start the day on a high note with probiotics that taste like the tropics. Mix it up with micronutrients that taste like berry or citrus. And take it all the way back with the classic AG1 Original with notes of pineapple and vanilla. Do your health a flavor, or 4, with AG1 Next Gen, the daily health drink. Learn more at drinkag1.com.
So one key thing to know about the volatile anesthetic gases is that they can trigger a condition called malignant hyperthermia. Now, I do have an episode on malignant hyperthermia if you're interested in taking a deeper dive into that topic. And that is in episode 302. Episode 302 takes you into more details about malignant hyperthermia. So I'm not going to go into the whole thing here, but in general, it is a very dangerous reaction that leads to a hypermetabolic state. Complications include hyperthermia, hyperkalemia, myoglobinuria, cardiac arrhythmias, acute renal failure, DIC, metabolic acidosis, and yes, if left untreated, and sometimes even with treatment, death can occur. Now, nitrous oxide, which is a non-volatile gas, does not trigger this reaction. Alrighty, so let's go through these key gases. First, we'll start with halothane. It is going to have the highest likelihood of the volatile gases to trigger malignant hyperthermia. And it is not used in patients who have liver dysfunction or reduced ejection fraction, like say they have significant heart failure, or patients that have pheochromocytoma. And one of the things that halothane can do is it can cause fulminant liver necrosis. So even if you don't have liver dysfunction, it can still really do a number on your liver. So guess what? Halothane is not commonly used. Next, we have isoflurane. Now, this one has a very pungent odor. And this very pungent odor is very irritating to the airways. So patients receiving isoflurane are at higher risk for bronchospasm and laryngospasm. So it's going to be avoided in patients who have restrictive airway disease like asthma or COPD. Laryngospasm and bronchospasm, that is highest risk when we're using it for induction or during emergence. So it's typically used when it is used for maintenance, not used for induction. And one thing to know is that it can cause reflex tachycardia. So that was isoflurane, very pungent odor. Desflurane is basically very similar to isoflurane. It's got that pungent odor. But this one has one key difference. It has the highest risk for carbon monoxide poisoning due to byproducts of the gas itself. So isoflurane and desflurane, very similar, but desflurane does produce that carbon monoxide as a byproduct. And then sevoflurane, probably the one I see used most commonly. Now, sevoflurane is sweet smelling, so it is suitable for mask induction. You'll often see it used for mask induction with pediatrics for this reason, less risk for laryngospasm, but do note that it can still occur. You're always going to be thinking that laryngospasm, bronchospasm, any kind of complication could occur with any of these anesthetic gases, but with sevoflurane, it is less likely, and it is considered the safest of the volatile gases for patients who have asthma. Now, the byproducts of sevoflurane do not create carbon monoxide like desflurane does, so yay for sevo, and it is, however, avoided in patients with renal disease. Again, sevoflurane is the most commonly used inhaled anesthetic, at least in my experience and what I saw as I was researching for this episode. So those were the volatile gases. Halothane, not commonly used, most likely to cause malignant hyperthermia. Isoflurane and desflurane, very pungent odor, definitely not using these for induction because of that high risk for bronchospasm and laryngospasm. And then desflurane does have that carbon monoxide byproduct. And then sevoflurane, which you'll often just hear called sevo, as in the anesthesiologist will say, I ran him on sevo, and now you'll know what that means. Sevoflurane is more sweet smelling and can be used for induction. You'll see it used with kids. You'll see it used with patients with asthma, but you will probably not see it used in patients with renal disease. So then for the non-volatile gas, the nitrous oxide. Now, one thing about nitrous oxide is that it can increase ICP. So that's one thing to know about it. And it is the least potent of inhaled anesthetics. As I mentioned earlier, if you're using it for general surgery, it must be combined with some other agents. It's not going to do the job all on its own. And it is avoided in pneumothorax, in bowel obstruction, in middle ear surgery because it can expand airspace. We don't want expanded airspace in any of those conditions. And after nitrous oxide is discontinued, there is a risk of a diffusion hypoxia. So it's really important to maintain 100% FiO2 for a little bit of time after that nitrous oxide is discontinued. Okay, let's talk a little bit about anesthetic gas adverse effects and complications, and then we'll wrap this one up. So adverse effects of anesthetic gases include postoperative nausea and vomiting, or PONV. If you see PONV, that's what it means, postoperative nausea and vomiting, bronchospasm, laryngospasm, and hypotension. So basically, these are the key things that you're watching for in that post-anesthesia period. So let's talk about each of them a little bit. So PONV, that post-operative nausea and vomiting. The reason this is such a big deal, it's not just that it's uncomfortable for the patient, but post-op nausea and vomiting can cause the patient to aspirate, right? They're not fully awake, they're not fully aware, their gag reflex may not be totally back, their cough might be still weak, and if this patient's laying on their back and they have vomiting, that's extremely, extremely dangerous. So, and it's also uncomfortable for the patient, and it's really painful, especially if the patient has had like an abdominal surgery or a thoracic surgery, and now their body is retching. Oh my gosh, the pain. So we don't want post-operative nausea and vomiting. So what we'll do is the patient will get prophylactic anti-nausea medication or antiemetics, and these are often given right toward, at some point during the case, during the surgery by the anesthesiologist, and these include ondansetron, which is Zofran, and metoclopramide, which is Reglan. Dexamethasone is another one, and sometimes you'll see all three used very, very commonly. Now, dexamethasone is going to possibly cause that blood sugar to go up a bit, so don't be surprised if your patient's blood sugar is a little bit high after surgery and you look in the chart and see, oh, they got some dexamethasone. So just be aware of that. And then Emend, I'll try to pronounce the generic name. Oh, I don't know. I might butcher this one. Aprepitant. I don't know. We just call it Emend. This is given prior to surgery. You'll also possibly see scopolamine patches as well, which go right behind the ear. So those are all things for post-op nausea and vomiting. And then another complication is bronchospasm and laryngospasm. Now, sevoflurane and nitrous oxide are going to be least likely to cause airway irritation, but even with sevoflurane, bronchospasm and laryngospasm can still occur. Definitely more likely with desflurane and isoflurane. And then hypotension. Volatile anesthetics reduce systemic vascular resistance, and this leads to hypotension. The effect is obviously going to be more profound if you've got a patient who's hypovolemic for any reason. They've been bleeding, they are severely dehydrated, whatever that is. So watching for hypotension. And now some anesthetic gas complications. Now these can vary based on which agent is used. So just a few little tidbits. With sevoflurane, a complication that can occur is nephrotoxicity. Remember, I said sevoflurane is not going to be used in a patient with renal disease because it can cause nephrotoxicity. With desflurane, it's that carbon monoxide poisoning. And again, the laryngospasm, bronchospasm is possible. And then with nitrous oxide, prolonged exposure, and it didn't really say what was considered prolonged exposure, but it can cause hematotoxicity. And then with halothane, which really isn't used that much, hepatotoxicity, which is liver toxicity, and reduced cardiac output. So there you have it, your quick overview of anesthetic gases. So if you're heading into that periop rotation or taking an exam or switching over to a new area of practice, now you'll kind of have an idea of what people are talking about when you're getting a report or you're reading the chart and seeing what gases the patient was run on or what the case was run on during the procedure. So you kind of have an idea of what to expect and what to watch out for and questions that you might want to ask the anesthesiologist. I hope you found that helpful. And again, if you want to dive into malignant hyperthermia, go back and listen to episode 302. I just realized, wow, we're on episode 432. So that is 130 episodes ago. Oh my gosh, where does the time go? All right, I'll see you all again soon. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
The road is calling. Embrace the thrill of the drive with the fully electric Audi Q6 e-tron. Featuring effortless power, serious acceleration, and advanced Audi tech. It's not just a new EV, it's a new way to experience driving. The fully electric Audi Q6 e-tron. The next chapter of Audi is here.